Well, good morning, everybody. Scott. Most people have that. Just these two. Uh-oh. I forgot to turn on the projector. Yeah. There we go. So you have anatomy at 11:30. Well, I'll understand if you're a little bit distracted. If you have questions, I don't think did I send you a copy of the highlighted exam?
Yes.
Okay, I mean, I posted it or sent it. Okay. So if you have questions, please find some time to talk to me because I want you to clear up any concepts that you don't have. Discuss with your colleagues first if you want to do that. And if something's not fitting, grab a friend and we'll figure out a time when we can get together and go through things. Okay, there's two last slides for this cardiovascular section I want to talk about. And then also tell you some material that you're expected to learn on your own. Now there's at the end of this section there is cardiovascular disease patterns. And hopefully now that you have really a pretty decent foundation of cardiovascular physiology as you go through those disease states, and this will be kind of your segue into your clinical pathophysiology course. When you read those sections on hypertension, coronary artery disease, heart failure, many of these we've talked about, they'll fit. So I do want you to study those sections, and then, you know how I mentioned how cardiac cycle, you just have to kind of learn it. Nobody can really teach it. Somebody can help you with it, but you have to start learning it on your own. Well, same kind of thing with hemostasis. Learning the cascade, the coagulation cascade. And this is going to be very important in your professional life. So, do work through this on your own. I'll be happy to help with questions, and we'll refer to some of this later on. But do work through hemostasis on your own and go, okay, this factor goes this goes with this. Oh, here's a common disease. We have a deficiency here, so everything downstream is impacted. Yeah, this should be on that last page of your next to last page of your cardiovascular notes, right? Okay. Now, I do want to talk a little bit about regulation of what happens when the heart has to work harder and the regulation of blood flow. When the heart has to work harder, let's say you're called upon to do some physical activity. Well, you know that's going to pull off your parasympathetic nervous system activity. It's going to stimulate your sympathetic nervous system activity. Your heart's going to start beating faster. It's going to beat harder, eject more blood per minute to supply those working muscles. But remember, the heart has to supply itself. It is a muscle. So in a normal, healthy person, you have the coronary vasculature that it's quite remarkable that you can increase coronary blood flow just like you can to the periphery according to need in a healthy person. A lot of people you'll be working with won't be that healthy person, but you learn the basic first. So when you place more demands on the heart, meaning cardiac output's going to go up, maybe mean arterial blood pressure goes up. That'll make the heart work a little bit harder. That means that the myocardium, those muscle cells, have to do more work. They're contracting more rapidly. They're contracting more forcefully. If afterload, meaning arterial blood pressure is going up, they're having to eject blood against a higher force to get it out into circulation. So when you call upon the heart to do more work, it'll do more work automatically. You don't need to think about it. It'll do that primarily via autonomics and other things. But you tell me what happens, and it's the same thing as we talked about in the periphery. To a large degree, there are some differences here, but if any tissue starts to work harder out here in the periphery, what does it produce more of? Metabolites. Local metabolites. The harder a tissue works, the more local metabolites it produces, right? And what do local metabolites do to blood flow? Or I should say, what do local metabolites do to resistance to blood flow? They decrease. Local metabolites, as a general rule, are vasodilating. So, you tell me what happens if that heart is working harder. Is it going to be producing more local metabolites? Yep. Do you think the coronary vasculature is going to have increased resistance or decreased resistance? Decreased resistance. So guess what? If you decrease resistance, what happens to flow? It goes up. So as the heart works harder, there's more oxygen demand for those working myocytes. Guess what? Local vasodilating mediators opens up that coronary vasculature even more, and you get more blood flow. So it's very similar in that regard to what's going on in the periphery. So there is more blood flow required to the working heart, and guess what? The vasodilation, due to the release of those local vasodilating mediators, will allow that to happen in a normal healthy heart. But, so you have a nice matching to increase work, increase coronary blood flow, increase oxygen delivery. Less work, less coronary blood flow, less oxygen delivery. Just what you want. There's a nice matching. But what happens if somebody has a coronary artery disease? And your book does show it, and I wish I would have brought in a set of slides. So normally you have a vessel that's like that, but let's say it's 80% occluded. 80% occluded. So a person who has atherosclerosis, so we have building up of plaque inside a coronary artery, they have less of a reserve for increasing blood flow. If their heart's doing work, will they increase blood flow? Yeah. But they might hit a ceiling, and they just can't increase blood flow anymore. Whereas a young, healthy person, and they're 20 years earlier, they could have increased their blood flow to their heart even more and more and more. But because of occlusion of that artery, they can't increase it to the degree that's necessary. So what's going to happen? So you have a limited blood flow going to a heart that's working harder. Insufficient blood flow to any area is called ischemia. So this would be an example of myocardial ischemia. The blood flow doesn't match the demand. So if blood flow doesn't demand, you're not getting sufficient oxygen to that tissue. You're not getting rid of CO2. You're not getting rid of other metabolites. This can lead to problems. If you have ventricular myocytes working harder and harder and harder and not getting sufficient oxygen, you will run into hypoxia. So hypoxia is insufficient oxygen. So myocardial ischemia is insufficient blood flow, and if it persists you will lead to tissue, in this case myocardial hypoxia. This can do some bad things. Number one, for some people, that's going to lead to feelings of pressure, even pain in the heart. Okay? That's not always a bad thing, because that tells somebody, okay, I need to slow down. It's a bad thing that you're having pain. It means you have an underlying problem, but that discomfort causes people to slow down a little bit. But what can happen with that myocardial ischemia and tissue hypoxia is, what if there's insufficient blood flow to certain areas of the conduction system? Those conduction cells, they need to be supplied by blood flow too. And if their blood flow is somehow compromised, what can happen? You can have disturbances in that conduction system. And remember, it's very coordinated how it goes from SA node to AV node down the bundle to His, the right, left bundle branches of Purkinje's to the myocytes. So what if you have, in specific areas, decreased blood flow to some of those conduction areas? That can lead to conduction disturbances. That can lead to dysrhythmias. Dysrhythmias, arrhythmias mean the same thing. So if the heart is working harder, but it's not getting sufficient blood flow, not getting sufficient oxygen delivery, you might have conduction abnormalities, which can cause dysrhythmias. And you know that there is this order: membrane depolarization, leading to muscle contraction, leading to pressure generation, leading to ejection, right? And if you disturb anything in that list, everything downstream can potentially be impacted. Membrane depolarization, that is being driven by the conduction system. So dysrhythmias can very quickly cause all sorts of problems in the mechanical properties of that heart. So, in a typical healthy person, more work, more coronary artery blood flow, more oxygen going to that working myocardium. But if coronary artery disease is present, blood flow may be limited and ischemia may result. That may lead to angina. And ischemia may also lead to dysrhythmia. So, lots of times you have to think about myocardial work. What are the determinants of how hard the heart works? Because if somebody has, and you're going to see in those pages, a number of different types of underlying heart disease. If not every patient with heart disease, but there's certain types of heart disease that, what does the clinician want to do? The clinician wants to keep that patient from getting the heart to that red zone. Doesn't want the person to do so much myocardial work that it can lead that insufficient blood flow, that insufficient oxygenation. So what do? You give medications that limit myocardial work. You give medications to limit myocardial work. So what are the determinants of myocardial work? And I really hate this word that's going to pop up, but this happened during an oral exam with a grad student that I knew, and somebody asked her a question, so she goes to the board and she just writes it down in this order, and none of us had ever noticed this before, but contractility. The higher the contractility, the more work the heart's doing. So if you want to limit myocardial work, you give a medication. One option is to give a medication that limits contractility. You have some ideas what that would be. Rate, heart rate. The faster the heart beats, the more the heart's working, the more blood it demands. So that's a determinant. Afterload. Afterload's that mean arterial blood pressure. Remember that ventricle? And unfortunately, I grabbed the wrong slide. Here we have aortic regurgitation here. We have a valvular insufficiency. But afterload is the load that that ventricle sees after that aortic valve pops open. And so that's mean aortic blood pressure. So the higher the blood pressure, the more the heart has to work. So if somebody has systemic hypertension, if blood pressure out here instead of 120/80, that's a mean arterial blood pressure of about 93. What if their mean arterial or mean aortic blood pressure would be 105? You're having to generate extra pressure in the ventricle to allow blood to be ejected. More pressure generation, more work. So afterload, mean arterial blood pressure is a major determinant of how hard the heart has to work. So preload, remember preload is filling the heart, filling the heart. If you fill the heart with more blood, it's going to eject more blood. So ejecting more blood takes more work, more ATP. So these, and this is pretty easy to remember, so what we would tell, and I kind of started using this when I talked to practicing dentists, when they would be giving too much anesthetic with too much epinephrine to patients with heart disease. If you have somebody who has insufficient coronary blood flow to begin with, and you give them too much epinephrine along with their local anesthetic, you can get into a world of crap real fast. You can start making that patient, so this happens. Somebody comes in with heart disease and you can't get them numb, and they inject them with there's X number of ampules you're supposed to be able to have anesthetic with epinephrine you're supposed to give if somebody has certain degrees of cardiovascular impairment. And if you exceed that, some of that local epinephrine can get into the bloodstream, that heart begins to work harder, and you can drive somebody to angina while they're lying flat, give them treatment. So you never want to cause a crappy situation. But this also tells you what you can do if, hey, if this person is limited here, what can we do? You already know about some medications that you can give. So you give medications that will help reduce each of these. And for example, there are a number of people that have had myocardial infarctions that in different areas of the heart that you don't want the heart to work too hard. You want to limit myocardial performance. Will that limit what the person can do physically? Yeah. But you don't want to push that heart in the red zone to either cause irritability of the contracting myocytes, or even more scary, some type of insufficient blood flow to the conduction system that can lead to some dysrhythmia, that can lead to some very dangerous dysrhythmias very quickly. So you can understand a lot of people with pulse myocardial infarction, they're on beta blockers and diuretics. And diuretics, that's going to decrease preload. Not everybody, but this is just one example. You decrease preload, you decrease the amount of work that the heart has to do. You put them on a beta blockers, well, guess what? You're going to limit their maximum heart rate. You'll limit the contractility of the heart. That's going to decrease myocardial work. If you give a beta blocker, you decrease the release of renin, so you're going to decrease the release of angiotensin II, or the production of angiotensin II and aldosterone. That will decrease preload. And angiotensin II is a very powerful vasoconstrictor, so giving diuretics and beta blockers, you are actually driving all of these down. So this is actually total peripheral resistance is afterload. So it doesn't take much medications to stack on somebody. You decrease their potential myocardial performance, which might keep their heart out of the red zone. So that's just a little link between how hard the heart works and some things we've already talked about with using receptor antagonists or diuretics or something like that. Okay. Okay, with that, we're going to switch to what Dana's been waiting for. Pulmonary physiology. And here are some things we're going to be going through. What we're going to be concentrating on today is ventilation. Ventilation is getting air in and out of the lungs. We're going to be talking quite a bit about ventilatory mechanics. So, what we're going to talk about in ventilatory mechanics is how do we get air in and out, and then we'll turn to something called lung volumes and capacities, corporate breathing, and then terms. We have to work to get air in and out of the lungs, and there's two major determinants. We'll look at that. So why do we breathe? Why do we breathe? Why? Nobody knows. Amazing. We need oxygen. That's the first thing that comes up. That's very important. What, believe it or not, is even more important? Get rid of carbon dioxide. Exactly. We're going to see most of our ventilatory drive in humans is to get rid of CO2. Absolutely right. So we breathe, we get rid of CO2, we breathe because we need oxygen, and there are a number of other things as well. pH control. So how do we breathe? Think back to the courses you've had before. Negative pressure ventilation, negative pressure ventilation. We're going to do some muscle contractions leading to pressure volume manipulations that draw air in. We're going to make a negative pressure, and negative pressure suck. They draw air into them. So I'm sure you remember that the normal inspiratory muscles are the diaphragm and the external intercostals. When you make an inspiratory effort, your diaphragm dips down, your external intercostals lift your chest wall upward and outward. That's going to help draw air into the lung. If you make a deeper inspiratory effort, well, you contract your diaphragm and external intercostals even more, but boy, you can just tell this. Grab your sternocleidomastoideus and just take a deep breath. When you get clear up to the top, guess what? It contracts. You can't take a total inspiratory effort without that guy contracting. So what's that doing? It's pulling up the top of your rib cage. Your scalenus muscles are doing the same thing. Your pec minor is doing the same thing. Normal expiration, all we do, just imagine a balloon that has been filled with air. There's elastic recoil potential. For normal expiration, all we have to do is relax. And the elastic recoil potential drives the air out. No muscle contraction is required for passive expiration. Now, if we are going to do a maximum expiratory effort, so when you're just standing here, if you're going to just go from this relaxed point and exhale out deeper, that requires muscle contractions. That's abdominal muscles and the internal intercostals. The abdominal muscles are contracting, that's driving your diaphragm passively. Increase abdominal pressure causes your diaphragm passively to go up into your thoracic cavity. That pressurizes your chest. That drives gas out. And contraction of the internal intercostals drives your rib cage inward and downward, driving air out. So this is the way, a simple way of looking at the two lungs with the tracheobronchial tree. And in here you can see, here's the lungs, here's the airways. There are many alveoli, all these dots are alveoli. And here's your diaphragm, here's your chest wall. Well, that's just a little too busy. So this is what we're going to be looking at over and over and over for ventilatory mechanics. Here we have our conducting airway, the tracheobronchial tree. This one alveolus represents all the alveoli in our lungs. So here's our chest wall. Here's the margin of the diaphragm right here. This in here would be in the alveolus. That would be alveolar pressure. Up here, this is atmospheric pressure. When we're talking about blood pressure, we use the scale millimeters of mercury pressure. When you talk about ventilatory mechanics, you use a different scale. It's centimeters of water pressure. It's a much lower pressure scale because the pressures here are much lower. Yes, there's very little potential space between the lung and the chest wall. Some places you don't even see the space. So this does look incredibly huge, but so this is your thoracic cavity volume right here, and there is a potential space here between your visceral pleura and your parietal pleura. This would be your intrapleural space, and yeah, there's a pressure here. And you can see in this example, it's negative. It's a -5. It's -5. So this is what we're going to be looking at. Your conducting airways, this is just for air to come in and out. No gas exchange occurs with the bloodstream there. Is here at your alveoli. This is where you have gas exchange between the alveoli and pulmonary capillaries. That's where the gas exchange occurs. So each alveolus on average has 1,000 capillaries. 1,000 capillaries. So they are incredibly vascular. This leads to a high surface area for diffusion. So guess what? You have high diffusion potential here. You have like 500,000 alveoli per lung. And each lung has on average 1,000 capillaries. So, and each of those potentially gives surface area for diffusion. So if you would take just the surface area for diffusion of your lungs and spread it out, it's bigger than a doubles tennis court. That's a lot of surface area. That's a lot of surface area for diffusion. And that's just at the lung, okay? So here's alveolar pressure in here, the pressure inside there, and when we are just relaxed, mouth open, muscles relaxed, you know that there's air in your lung because you can breathe out. So as you're relaxed, there is this point where, yeah, there's air in the lung. You can still bring air in, relax, but you can let air out and do a forced expiration. The amount of air in your lung when you're just relaxed at this equilibrium point is called your functional residual capacity. Functional residual capacity. And your functional residual capacity, when you're just relaxed, I know that the pressure in my alveolus is 0 here because no air is moving. Air is a fluid. It flows from air to high pressure to low pressure. By convention, you take atmospheric pressure, the ventilatory mechanics is 0. If no air is moving, that means there's no gradient. That means it must be 0 right here. So what sets your functional residual capacity in this negative intrapleural pressure? When you are at FRC, this relaxation point, there is an outward elastic recoil of the chest wall. Your chest wall wants to spring outward. But all these alveoli, imagine like a rubber balloon, they want to snap back. They have elastic recoil potential, and they want to go inward. So this is going outward, this is going inward, and that causes the pressure in this space in between to actually be negative relative to atmospheric pressure. So intrapleural pressures are actually negative. And what does that do? That keeps that alveolus from completely collapsing down. Negative pressure sign. They're pulling the walls outward, okay? And so when you're relaxed, there's this equilibration point where the outward elastic recoil pressure is exactly equal to but opposite of the inward elastic recoil pressure. And that is when you were at FRC, that functional residual capacity. So this right here is what we have at rest when we're at FRC. This is our starting point for inspiration. So there's an inspiratory command that originates in your brain stem that tells the phrenic nerve to fire. The phrenic nerve controls your diaphragm. It tells the diaphragm to contract. This results in an increase. So the diaphragm is going to contract. Boom. When the diaphragm contracts, it goes downward. So what's just happened to your thoracic cavity volume? Is it increased or decreased? It's increased. So if thoracic cavity volume has increased, there's X amount of gas here. This is a semi-enclosed space. if the volume of the vessel increases, but the amount of gas in here is still the same, what's going to have to happen to pressure? It's got to go down. So what actually happens is when you contract your diaphragm, and that as thoracic cavity volume goes up, intrapleural pressure goes down. That goes back to something called Boyle's law. You had this in physics at some point. When you talk about an enclosed space, if you have a certain amount of gas and you increase the volume, you're going to decrease the pressure of the gas in that space. And it goes the other direction too. If you have a certain amount of gas in that enclosed space and you decrease the volume, you're going to increase the pressure. So Boyle's law is just saying that pressure and volume are inverse to one another. So if this was their starting volume, if volume increased, and that's what happens, the thoracic cavity volume increases when you contract your diaphragm, the pressure in there, that's called intrapleural pressure, goes down. It goes down. So we have a more negative intrapleural pressure. Now there's two ways you can think of this. But this more negative intrapleural pressure, it's going to cause action on these alveolar walls. You can just go with, and a lot of students just go, negative pressure suck. So this is more negative pressure. It's going to pull these alveolar walls outward. Or really what's happening is that's a higher pressure than that, so that positive pressure is going to push those walls outward. Either way, it's going to work for you. But when you make that inspiratory effort and that intrapleural pressure becomes more negative, what's that going to do? It's going to, as that intrapleural pressure gets more negative, it is going to draw those alveolar walls outward. So if alveolar volume increases, what has to happen to alveolar pressure? It has to decrease, and that's what happened. It was at 0, and now it's -2. Guess what? You now have a gradient for flow. Pressure out here in the atmosphere is 0. That's high pressure compared to what's in your alveolus. That's low pressure. So what happens when your diaphragm contracts? Diaphragm contracts, thoracic cavity volume increases, intrapleural pressure decreases. That's going to cause alveolar volume to increase. That will cause a decrease in alveolar pressure. This is a chain of events. This is a chain of events, and you really need to know this chain very well. That sets up a gradient, so guess what? As this distends, it goes from this position to -2. Air is now, you now have a pressure gradient, and that is going to allow air to flow into the alveoli. As more and more air comes in, that pressure in the alveolus starts to equalize with what's in the atmosphere. So as more air comes in, it drops to a -1, and the gradient slows. As air fills this alveolus, the pressure is going to drop to 0. And so when you make an inspiratory effort, air doesn't just keep coming in, it stops. So even though I'm at a higher lung volume, you can see a higher alveolar volume, because movement has stopped, I know at this point alveolar pressure is 0. Okay? So we started at 0. We made it negative. Air flows in. We're back at 0. Yeah.
So going back like a slide, when the alveoli starts to expand, does the thoracic wall continue to expand too?
Well, these things actually happen in real time together. As the chest wall is going out, the alveolar wall is going out.
Because otherwise, like, I mean, you just made it to -8, wouldn't increase in the volume of the alveoli.
You know, once you go from a 5 to a 6, that alveolar wall is already coming out. When you go from a 6 to a 7, so it doesn't wait to 8, it's happening in real time. And I have some slides that'll show that to you, but I can't print those out and what actually happens dynamically. So now we have all this gas in here, And now, if during normal quiet breathing, what requires more muscles to contract? Inspiration and expiration. Remember I said expiration is passive. All you need to do is relax. You now have stretched out these alveolar walls. So imagine like a balloon. These alveolar walls wants to snap back. They have elastic recoil potential. So once the diaphragm goes back to its original position, intrapleural pressure is going to go back to what it was before, at -5, right? And so now we have less of this distending pressure to hold these alveolar walls outward. So what happens? The alveolar walls now want to snap back. And when they do that, what do? Is they pressurize the gas in your alveolus. When they snap back to that original size, they're pressurizing the gas. Why? A decrease in alveolar volume leads to an increase in alveolar pressure. We now have a gradient for air to flow out. And so air will flow out, and flow out, and flow out, and finally we get back to zero. So tidal expiration, that's what you're doing, tidal breathing, just air going in, going out. Tidal expiration is passive. All you do is relax. Diaphragm goes back to its original position. Thoracic cavity volume decreases. Intrapleural pressure increases. Alveolar pressure, or alveolar volume decreases. Alveolar pressure increases. Air flows out. Air flows out. So on the written text, you have like 7 steps for inspiration, and then I cut it down to, and expiration is just in reverse. I think I reduced it to 5 steps. Know those chains of events very, very well. There's a lot of different pathological problems that can affect those chain of events. So this is getting what Becky was saying. So this really shows more about this happening in real time. You know, as soon as that's going down, those alveolar walls are going up. So it's just like this. One leads to another, but they're happening instantaneously. Okay? Does that make sense to you? Hopefully. So that's kind of important to see that actually happening for a lot of people. Here's the 7 steps. This is just what we talked about. Just like the SA node sets the pace for the heart in a normal healthy person, you do have pacemakers in your brainstem. Now you can modulate that pacemaker just like you can modulate the SA node and make it fire faster, make it fire slower. We'll see that there's a number of different things like chemoreceptor input and joint receptor input that will speed up or slow down the firing of the pacemaker. So here are those steps, they're in the text, what we just went through with pictures. Now, here's this 1313, and I gave you an expansion of this that it's very important. It's very important to be able to understand, okay, what's happening dynamically. So here's intrapleural pressure right here, and this is various pressures. So this is intrapleural pressure. It's going down during an inspiratory effort. So what's happening is alveolar pressure goes down, but as the alveolus fills with gas, it goes back to 0, and so here's air coming into the lung. And then here's expiration. So this is the inspiratory phase. That's the expiratory phase. And that one-page handout I gave you links a lot of whole other things with them. So what do you do if you want to take a deeper breath? Well, guess what? You just contract the diaphragm farther. You contract your external intercostals, it'll lift the rib cage upward and outward. And if you take a very deep breath, you contract your pec minor, your scalenus muscles, the anterior, medial, and posterior, and also the sternocleidomastoideus. Those will lift the rib cage primarily upward, but a little bit outward. And what does that do? That makes for a more negative intrapleural pressure. That will cause the alveoli to distend outward even more. That'll cause a more negative alveolar pressure. That's going to cause more air to flow in. And it'll come in faster. It'll come in faster. So you take a deeper breath. You just make these numbers more negative. More air will flow in. And then you just relax. Boom, air goes flowing out. So normal tidal expiration, as I mentioned, it's passive. All you do is relax, and air will be driven out. So what happens if we do a forced expiration? Is I'm just relaxed here. I'm at FRC. I can exhale out. How can I do that? And I've already mentioned that you can contract your abdominal muscles. You do it, you just relax. You relax, put your hand on your abdominal wall, and you can exhale without making those muscles contract. So your abdominal muscles are contracting. That is increasing the abdominal cavity pressure. That's passively, that diaphragm is relaxed, but that's driving the diaphragm upward, and the contraction of your internal intercostals is causing your chest wall to go inward and downward. Both of those are decreasing thoracic cavity volume. If you decrease thoracic cavity volume, what has to happen? Intrapleural pressure has to go up. And that's what happened. Intrapleural pressure goes up. So this is going to be pushing in this direction, and the alveoli, they already want to snap down anyway. So what does a forced expiration do? It pressurizes alveolar gas, causing air to flow out. Okay, now, sometimes your patients are not going to be able to ventilate for themselves. And then people like Tina step in and take care of them. And what I'm about to show you is so incredibly simplistic, she's just going to be sitting back there shaking her head. But we're going to just look at mechanical ventilation. And if somebody is unable to generate the ventilatory drive to breathe by negative pressure ventilation, and that occurs a lot of ways. You can have damage to your respiratory centers. A really close professor of mine, right before, when I was here in Nebraska, and right before I went in to start talking about ventilatory mechanics, I get a phone call 5 minutes before. He was hit in the back of the head by a bus rear view mirror. The bus had to swerve and get close to the sidewalk, and it transected his brainstem, so he lost all ventilatory drive. So of course, he had to be put on mechanical ventilation because he did not have that neural outflow to do what we just talked about. Also, if somebody's in deep plane surgical anesthesia, they've lost their ventilatory drive due to CO2, you have to ventilate for them. So, mechanical ventilation, since this person can't do that negative pressure ventilation for whatever reason, one way of ventilating that person is by positive pressure ventilation, positive pressure mechanical ventilation. So the pressure here out the nose and the mouth is actually pressurized to set up a pressure gradient to drive air into the lung. Okay? And pressurized gas goes into the lung, and then how do you get it out? Very simple. All you do is take off the pressure here, and the elastic recoil of the alveoli is going to pressurize the gas, and it's going to come out. There's a lot more to it than that. She's sitting there going, and I agree with her. I agree with her. So there's this oscillation back and forth, back and forth. Now, smart ventilators and all ventilators, they'll go along and they're measuring a lot of things in real time. And you know, you're around somebody, and every now and then it'll have a deeper, I can't call it an inspiratory effort, but there'll be more air going in to ventilate poorly ventilated alveoli, and then you hear it come off and it sounds as though the patient sighs. Well, the ventilators are very smart, and they don't just little bit in, let the same amount out, little bit in, same amount out. Not all of the alveoli are ventilated at the same degree, so sometimes you have to help the person's lung take a deep breath. So you put in a little bit more, and then more comes out. And you know, if you're at the bedside and you're not prepared for it, you're all concerned about your friend, and you hear this, think, what the hell happened? You know, well, the ventilator is smart. Okay, so negative pressure is what we do. Think of it, it draws air in. It draws air in, but positive pressure ventilation, and we're not even getting to the important stuff like positive end expiratory pressure and so forth. You're going to get that a lot later on. But positive pressure ventilation is basically driving air in. There are some negative consequences of positive pressure ventilation on what it does to distribution of blood flow and so forth. But it's keeping the patient alive right now, and for a really quite a long period of time. You can deal with the other things later on. So negative pressure ventilation, if you conceptually think, okay, how is the air being drawn in, and then think about positive pressure ventilation, why is the air being driven or pushed in? So this is from your book, and it's showing positive pressure ventilation right here. Mouth-to-mouth resuscitation breathing is positive pressure ventilation. Years and years ago, there were people who were afflicted with polio that it lead to, among other things, paralysis of the diaphragm. So back in the 40s and 50s, and even there was a second wave in the 60s, people would be put into iron lungs, and what they would be put in the sealed chamber, and really this chamber would do negative pressure ventilation for them. The pressure in here would become negative, pulling the chest wall outward, causing an increase in thoracic cavity volume, a decrease in intrapleural pressure. Air would flow in. Air would flow in. Now there's all sorts of things like chest shells and jackets, pneumo belts, diaphragmatic pacing, a number of different ways to help a person ventilate for a long period of time in an independent, mobile situation rather than being inside a box. For the longest lived person who was in a iron lung, she just died like 6 months ago. She lived in Tennessee 6 years ago. She was in an iron lung for something like 65 years.
She died and she was like still in the...
Oh yeah, she was in the iron lung the entire time. And she, unfortunately, they had an electrical storm and it knocked out power to the house, and the batteries went down before they could get a generator. So she was pretty much at peace. This is it. And you know, just incredibly sad. But she'd been, boy, I'm trying to think, it was 68 years she spent in iron lung. It was a long time.
Do they still use it nowadays?
Well, they use something like that. Still, there's something like that, but you don't put people in iron lungs anymore. There are still functional iron lungs out there.
There are, but you can't get parts for them anymore. And so
That's
if they break
just
down,
it. There's nobody making them.
Yeah, there's nobody
And
to
so
make them.
there are still people that are younger than that lady that are still in iron lungs, and it breaks, you know.
Yeah.
So, scary stuff. Scary stuff. If you do Heimlich maneuver, you're actually, think about what you're doing. Unfortunately, they took this out of this edition of the book. You're driving, I put this in, and I doubt if this is going to work. We don't have volume.
Oh, you can turn off the volume.
I don't think.
maybe the volume's on, let's see.
You want, it's down here.
Oh, well, it's not, I don't think it's gonna work. I don't think it's going to work.
It's down here.
Well, because it looked to me like it was just going to progress.
And I'm like looking at him like this, and he looks at me like this. I said, "We're going to do this." He goes, "Woo!"
Okay, well, that's me. Talking about an incident many, many years ago. And this is one of my students. You can tell my students respect me greatly. I was at Golden Corral, lived there North 27th, last time I was there. This is 7, 8 years ago. And I do this because some of you, as a civilian, you might have performed the Heimlich maneuver. Any of you have performed the Heimlich yet? Okay. Were things pretty well stuck? It is interesting you both were sitting close together. When you did it come popping out easily? Or did you? Okay, so there's this guy, he's sitting over here at another table, and I'll try to make this quick. And I was with my family, and you know, we're just talking along, and I just happened to look over, and he had taken a bite, and he kind of gives this quizzical look on us. And I look at him, and he looks at me, and we kind of acknowledge each other. He kind of goes, he takes a glass of water, tilts it up, and the water comes down the side of his mouth. So his eyes go up, and you know, my eyebrows, I'm sure, were going up, and he's like, ooh. And I look at him and I go, "We doing this?" And he goes, "Ooh." And so he and we stand up simultaneously, and you know, you don't even think about it. The people over here are like, "What are you doing to Grandpa?" And you know, I grab him, I spin him around, make the fist, go to his abdominal cavity, and I push, and I hit a rock wall. Did you hit a rock wall? I mean, I thought, a rock wall. So there's 3 of you who have done this, okay? And I hit a rock wall going, well, that's not gonna work. So I went, whack! Yankee pot roast came out. And you know, it comes blasting out, it hits the window, that was a pretty sight. And he turned, "Hey man, thanks man." And he says, I got it, I gotta go outside, and I'm like, I think I do too. And so we're outside, he says, "Did you just say my," I don't know. But you know, the family, "What did he do to Grandpa?" We come back in, they've cleaned the place up, and everybody's like, "What exactly just happened?" He Heimlich me. So, if you have to do this, don't be surprised. When you did it, was it just really hard? And then you go and you go, bang! And boy, that's 10 seconds afterwards, you realize when it yielded to pressure and it came out and that abdominal cavity went in, that's an incredibly satisfying and stress-reducing feeling for the guy choking, I'm sure, but me too. So if you have to do a Heimlich, don't be surprised if you really, really have to work. This was a bigger guy. It was a bigger guy, and you know, if it would have been a smaller person, they might have had a tough time Heimliching that gym. So it still kind of gets me kind of cranked up thinking about it.
Can we watch that video one more time? Maybe you can send us a link.
Yeah, we were not ready for it.
Oh geez, it's been recorded again. I didn't get quite so demonstrative this time. So there's some things that you're going to see all the time. What happens if a chest wall is breached? And you know, anybody who's watched any medical show, here goes, "Oh, we got a sucking chest wound here." So what do we have here? We have a gradient for flow. We have a gradient for flow. So what's the consequence of that? As if the chest wall is breached, the lung will often, will the lung itself, will it expand? Or will it collapse or remain stable?
So the lung was, at the beginning remained stable, then collapsed.
Yeah, there's a lot of elastic recoil potential here, a lot of elastic recoil potential. So it really depends on the degree of breach. Now, I lived in New Orleans for a long time, and I'd go over to Charity Hospital before Katrina wiped it out to have lunch with a friend. So you go run across, they didn't have an emergency room, they had what's called the accident room. And I don't know how many chest wall breaches I saw just walking through. And so when you have a chest wall breach, air is going to flow from very high pressure to low pressure. And what does that do is intrapleural pressure goes down. Remember, that intrapleural pressure is pulling those walls outward. That distending pressure goes down, so that means the parts of the lung may collapse. Parts of the lung may collapse. And so that'd be a sucking chest wound, and that can lead to atelectasis, which is, you know, a collapse. And ASIS means a condition of, ECT means out, tel means distant, and A means not. So it's not distended outward anymore for any distance. It's collapsing inward. And you take a look in your book. Well, actually, you have to go online to see your online portion of the book, and you can see, here's the wall of the lung right here. It's pretty faint, but you can see it. So that person's lung has collapsed somewhat. So this would be an example of a pneumothorax. There's air inside the lung causing this collapse. You can also have a hemothorax. Imagine we don't have this breach right here, but something is causing a bleed in the chest wall. As blood accumulates in here, and then as more and more blood accumulates, that will basically cause an extra pulmonary compression. As blood fills this space, it's going to squeeze down on those walls, and air's going to come out. So that would be a hemothorax. And here's another one that you do see. What if the lung wall is breached? And this happens all too often. Somebody with emphysema, or there's certain pulmonary diseases. What happens if you get a tear in the lung? Well, you have a gradient for airflow. So in this case, the air is going in this direction. It's going to go out of the lung, causing collapse right there, localized collapse. And in the other courses I teach, I show people going to concerts too close to speakers, and it's almost invariably young, thin males who smoke a lot, and I'm going to be right by the speakers, a lot of bass, boom, 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 boom. Not breathing so well. And it is surprising how many case reports there are about vibration from speakers causing this tears in the lung. And did you ever hear about that, Dana? You know, it's, you know.
Yeah, it's not, I mean.
It's not common.
It's not common.
It's
What's
not
more
common.
Is actually spontaneous pneumonia.
Pardon me? Well,
Spontaneous.
spontaneous in young, thin smokers, absolutely, but this is, it's a precipitating factor, and there's at least a dozen case reports out there. And all these guys probably, they were so close to having a spontaneous anyway, and then they just have a chest wall boom, 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 at a certain frequency, and it causes it's not really a chest wall, it's deeper, it causes a tear. So, if you're a metalhead, be careful. This would be a case of emphysema blood spontaneously rupturing because of pneumothorax. So, at this point, we're going to look at lung volumes and capacities, and I really do, the best way to do this is just go to the board. So imagine, if you will, you can put a lot of air in your lungs. You can put a lot of air in your lungs. So think of this as, this is the amount of air in your lungs. So we're just gonna use kind of this graph. Here's the amount of air in your lungs, and it's a certain volume. It's a certain volume. And like I mentioned, that there's a volume of gas when you just relax. I shouldn't say a volume, there's a capacity of gas when you just relax. But there's air in your lungs still, you know that, because you can breathe out. But there's still a volume of gas you can still breathe in. So most of you are just sitting right here with this amount of gas in your lungs, right here. Well, that is called your functional residual capacity. It's functional because you can breathe out a little, you can breathe in a lot. And for a 70-kilogram person, we're just going to say that's about 3 liters or 3,000 milliliters of gas. So let's just look at somebody taking an inspiratory effort. So somebody breathes in and exhales. Breathes in, exhales. Breathes in, exhales. Remember, you have to contract muscles for the air to come in, but all you have to do is relax and the air is going to go out. This is called tidal breathing. Air is coming in like the tide, air is going out like the tide. So that has a name. It's called tidal volume. And for a 70-kilogram person, they might be breathing about 500 mils per breath. Air going in, air going out. But you know, so I'm just going to put that line there, that FRC line. So you're going above your FRC, but when you relax, you come right back down to FRC. That's your equilibrium point, where the outward elastic recoil of the chest wall, inward elastic recoil of the alveoli, they're equal and opposite. Now we know that we can, when we make a normal tidal inspiratory effort, we can take a deep breath all the way up to here. So we have a whole inspiratory volume here that we can tap into if we need to take a deeper breath. This is called your inspiratory reserve volume. This is a volume that we can use if we need to. We normally don't, but if we need to take a deeper breath, we can do it. And that's about 2,500 mils of gas. And then I'm just going to relax. And even though I'm up here, all I have to do is just relax, and I'm back to here. Let me take a couple more breaths before I do what I'm about to do. I'm now going to make a forced expiratory effort. That's as far as I can go. Obviously, I have a little air in there. I want to be able to talk, but that's it. Okay. I had to contract muscles to get down here, so that was a forced expiration. Guess what? There's still gas in my lungs. I cannot voluntarily exhale out all the gas in my lungs. There's some gas left. It's called residual volume, and it's about 1,500 mils of gas remain in the lung when I do a forced maximal expiration. So what do you call this that I voluntarily exhaled out? That's your expiratory reserve volume. Just like your inspiratory reserve volume, it's about 1,500 mils. Now all I need to do is just relax, and you magically go back up to FRC. So this was very much active, this was very much passive. And I can start ventilating again from that point. So this whole area, this is called your inspiratory capacity. And if you put everything together, go all the way up here and load the lung as much as I can, that is my total lung capacity, total lung capacity. So this is the total amount of gas that I can put in my lungs. And I don't fill all these all the time. Normally I'm at FRC and I'm just doing tidal breathing. But if I need to take a deeper breath, I can, if I have the ability to exhale out more. Now, this amount of gas that I can voluntarily move, because remember, I can't breathe out residual volume. This amount of gas from the top of residual volume to total lung capacity, that is my vital capacity. Sorry about the garlic, but this is the capacity of gas that I can voluntarily move in and out. Are you noticing when you add volumes together, you get capacities? So, I'm going to show you one of the tests that's done. And so, if somebody's referred to a pulmonary medicine office to do full pulmonary function testing, they'll do all sorts of things, static volumes, measuring these things, but they'll also do dynamic airflow tests. And one thing they'll do is what's called a forced vital capacity test. So vital capacity is just this amount of gas that you can voluntarily bring in. But if I would take as deep a breath as possible, and then the respiratory tech goes, blow, 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 go, 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 all the way, all the way. I mean, did you have to be
Keep going,
motivated.
keep going, keep going, don't stop.
And, okay, now, this is gonna sound terrible, but if you're in the other room and you hear a respiratory tech, go, 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 all the way, finish, finish. And, I mean, you have to be highly motivated because you have to have a maximum effort.
And what's nice is you usually repeat the same test 3 times to get consistent results, so you
And-
really wonder.
And, you know, you do that 3 times in a short period of time, you'll start getting a little bit lightheaded. But what we have here is a forced vital capacity. This is you're blowing it out as quick and completely as you can. And in a normal, healthy person, the amount of gas that they can blow out in the first second is about 80%. They blew out about 80% of their forced vital capacity. So that's actually called the forced expiratory volume in the first second divided by the forced, vital capacity. In a normal, healthy person, they can exhale out about 80% of gas in the first second. But you're going to see that there's people with obstructive lung disease. There's an obstruction to airflow. They can't blow out that much gas that fast. There is an impediment to airflow. So, we'll talk about minute volume and minute ventilation and alveolar ventilation. For static, Dana, can you think of any other one? Those are the
also
general ones right there.
Depends, if you're doing a bedside PFT, pretty much your FVC and FEV1 is all you're going to be concerned with.
Yeah.
If you're doing a full pulmonary function test, like with fibrosis or something like that, you're going to get the FEV1, 2, and 3.
Yeah, yes,
So-
exactly. So, do know which volumes you have to add to get what capacities. And that, some of that will become more evident here later on. Now, when you send somebody to a pulmonary function lab, they've got the equipment to do all sorts of things, but many labs have simple spirometers. Many clinics have simple spirometers. And a spirometer, all it is, it's this mouthpiece that it measures how the velocity of gas movement and the volume of gas movement. So, yes?
The physiology lab has some, if you want.
Has spirometers?
We can
Okay.
bring some if you want to.
Every time we do it, we find a student that has something concerning. But what I want you to think about is, what can you actually measure with a spirometer, the simple device, and what can't you measure? Because all you can measure here is the amount of gas that you can voluntarily move. So with a spirometer, you can't measure residual volume. So any capacity that